to feature Dr. Maksim Shapiro. He graduated at the Albert Einstein College of Medicine and subsequently did a fellowship at NYU Medical Center. He created the spectacular website neuroangio.org, which is an exceptional educational resource, and we truly recommend it to any fellow resident attending interested in vascular and endovascular. His publications are also very high quality, especially those related to anatomical topics, of which I am a particular fan. Dural vessels anatomy, dural venous sinuses anatomy, etc. So thank you very much, Dr. Shapiro, for joining us. It's a pleasure for us to have you, and please, you can share your screen. You're mute now.
Matthias, thank you so much. Thank you for the introduction and for the opportunity to talk about this. Let me you see that okay? Can you see this?
Yep. We have it, yeah.
Great. Okay, well, thanks again. I've heard of it's a pleasure to be here, and I heard that the original promotion was, I love the Venous thing. I think it's great. The correction is fine, but I think I'll go with the original. There's so much that's like, truly legendary about that. I don't think my topic is not so well known, so to speak, but we'll get into a few things, and I hope it's going to be fun. Here are my disclosures. The one relevant thing I think to the talk is that we use, one of these embolic materials we use is onyx, and onyx is really indicated for pre-op embo of AVMs. So since we're not talking about that, that's going to be off-label, and other things as well. Want to acknowledge all my team. I think very much at NYU, it's a labor of love, and it's a big team. And what we're going to show and what Eitan showed a few weeks ago, it really isn't possible unless you're part of like a group that, where people complement each other and drive it forward. My talk's a little bit, part of this talk is sort of built on my some earlier work that has to do with how we approach dural fistulas. And so one of the ways is to think of it as this, different approaches, some a little bit more selective like this than others. And doesn't always work this way, but when it works this way, it's nice. So we'll talk about that. The videos never play, so these don't play, that's good. But I do think that in terms of science, and since this is a scientific foundation, I do think that my talk on the super selective embolization of these dural fistulas does have some like real scientific methodology to it. And we can go through some of the process of how that works, from the foundations of knowledge to the observation that we make pertaining to the topic, and the hypothesis, and how we test it, and the errors that we get into, that I think do apply to what we're going to cover. Now, for the ones, for the people that are not maybe so familiar to this in the audience, dural fistula is not, a lot of people never heard of dural fistulas. It's not a huge topic in medicine. It is important, certainly for the people that have this disease, and also is important because it is a particularly I would say, unique vehicle for understanding anatomy and understanding how we approach flow and vascular disease and what we do. It's basically, so what is it? It's a direct communication between dural arteries and veins in the dura and the cover of the brain. The main problem with it is that even though the fistula is not in the brain, it interferes with the venous drainage of the brain. And that's the main issue with it, really. The driver of pathology. They're not very common. We don't even know what the incidence of them is really, I think. But they're not too common. Usually acquired. The vast majority of them are acquired. We don't know a lot about them. There's always more in medicine that we don't know than we do. We don't really understand, I think, how it forms, the relationship between the thrombosis and the fistulas. I'm not sure is very clear at this point. The natural history understanding is, could be better. I think particularly in the lower, sort of like lower grade types. But we do know, I think, a lot at this point about the anatomy, the angioarchitecture of these things. And that has led to, I think, treatments that are improving, getting better and better, safer, more effective. So I think then that, and as far as obviously treatment is the goal, I think we're not doing too badly over there. The theme is to understand how pathoanatomy leads to better treatment, and that anatomy is the foundation of surgery. So the word foundation, I think, is germane here. And the foundation is this, that if you understand the disease, you have to understand the normal first, of course. And so we're going to skip, we're not going to get into the details of all these things, but fistula is a communication between arteries and veins. So you got to understand the arteries and the veins. In the artery side, beyond like the typical sort of like classic anatomy, there's a lot of importance to understanding these arterial arcades that sort of parallel the venous sinuses. So arteries and the walls of the sinus are very important. Some of them have names like the anterior meningeal artery over here. Some of them don't really have specific names, like a blood vessel that runs along the sigmoid or transverse sinus or the straight sinus. We should probably name them like that, but they're important. On the venous side, I think when we've talked about this a lot, it's important to appreciate that really the whole dura is kind of like a sheet of tissue that has venous potential. The sinuses don't have to follow these classic, paradigms of just running along the reflections of the dura. They could be anywhere. You can have them like this. You can have them like that. You can have all kinds of fenestrations and all these kinds of things. You can have this sinus, like this, that is without any pathology. You can have like an extra, kind of Falcian sinus that looks like that. So all of these things are important in understanding diseases. This thing that we talk about relatively a lot is these sort of dural venous channels, which are basically dural connections where cortical veins don't join the named sinus right away, but they go through these kind of like areas where they first join the dura, kind of a little bit away from the area where they normally classically might do. And that's actually much more common than I think is appreciated and has importance. Other things like all of these diploic veins, emissary veins are also important to understand. So all of that forms the background. Now we go a little bit to observation. So the next, talking about scientific paradigm and how we form our theories and so forth. So a lot of stuff starts with observation. Observation is, in this particular topic, would be this. So this is the earliest published that I know of, publication by Mironov about this super selective or selective transvenous embolization sparing the sinus, right? And that was published in 1998. He had a couple of cases where he noticed just an observation that somehow there's some sort of channel that runs next to the sinus that seems to be the recipient of a lot of these arterial arcades that feed the fistulas. And if you can get into that channel and close it, like he does here with this microcatheter injection, close that thing, then you can spare the sinus and kill the fistula. So you have the cake and eat it too. That's basically the idea. Reproducibility is big, right, in science and in everything. So other people, Pisky and others publish on this, got their cases. This is like an impressive looking fistula that you can cure with this like magic bullet kind of thing. So that's another account. Here's another case, similar, right? Sagittal sinus case. Now, here's another publication by Kishui. This group has been particularly active in this idea. So this goes back to like 2013, so almost 10 years ago. Use of, again, multiplanar images, rotational angiography, which is what we're going to get into too. This is switching to a little bit to methodology. Like, what methods do we use? This is one of the methods. The methods is these, quote unquote, then advanced and now more and more common tools, angiographic tools. you realize that the angioarchitecture of these fistulas is often consists of these kind of pouches that seem to be the recipients of a lot of the arterial supply, to the fistula. And these pouches, what he called pouches, is that what Mironov and Pischke would be calling channels. Basically talking about a similar thing that's common, right? People working different places, different names, but similar idea. You can close these things super selectively, and that can work. So, some cases that they showed, you see these early. It's often impressive how thoughtful and people that have the power of observation can achieve so much with what we think now is like relatively dated technology. You look at these images, you can understand. It takes a lot of, it's art, and it takes a lot of understanding of anatomy to be able to deduce things from looking at these. Now, so this has been our contribution to this work, and basically what we're talking about is expanding on this theme, on this like already existing theme of super selective transvenous embolization and what that implies for fistulas. This is our publication, mentioned it. It's basically just goes through the basic approaches to treatment of these dural fistulas. The classic ones are either transarterial, so going into all these different arterial feeders, injecting them with liquid embolics, and closing them that way. The transvenous approach is the other one, which is sinus sacrifice. That's the classic, closing it with whatever you want, mostly coils. And then the super selective one is this. It's basically understanding that getting into these channels and closing the channels super selectively to spare the sinus and close the fistula. It offers a lot of advantages, of course. The advantage is transvenous. You're not injecting arteries, so we're not, there's less possibility of all of these issues that we know of, which is the dangerous anastomoses and the cranial nerve injuries. Those are the two main issues with that. And also it's much more selective, so we're not permeating a lot of, territories that you don't have to permeate, and could potentially spare the sinus. The question is really, how common is this? Like we've seen a couple of cases. I think the real drive is like, are we talking about exception, or is it more the rule? And that's really what I think we need to see. So this is a review that you might have seen these cases before. I'll review them a little bit briefly, of typical sort of dural fistula cases. So here's a sigmoid sinus fistula. We don't want to get into the details of anatomy, but just like a broad view of what's happening. Okay, so this is, typical common injection. You see this fistula, various contributions, lateral tentorial arcade. Here's occipital artery, right ECA injection. Now here's, not uncommonly, there'll be some kind of PL dural anastomosis. So this is, it's also a topic we can discuss, but here's, some contributions from, you can see that either from the pica or from the posterior meningeal arteries. There'll be contributions to those. The lesion is really in the dura, and that's the important part. Even though there may be contributions from whatever SCA, picas, or wherever they may be from intracranial arteries, brain arteries. Really, the seat of disease, and that's what really is what this is about, is where is the seat of disease? Where is the disease? The disease is in the dura. So any of these other things are PL dural anastomosis. They're not primary, brain arteries supplying this. Very important to understand how the normal brain drains and so forth. So here's an occipital injection. Now you see, so you see on the occipital injection, some supply to from the left side, supplying the right fistula. And this is where things kind of like, we'll get into the understanding of this, like where exactly is the disease? When you look at this, it's a ton of vessels here, the torcular region. Is that where the problem is, or the problem somewhere else? There's a lot of this has to do with understanding. This is how this particular fistula was treated. So you see a transarterial onyx, more, and so here's a couple of other attempts more proximally that weren't very fruitful. Here's another case, again, left-sided fistula, big, lot of contribution, relatively more congestion here. Again, here's whatever, again, some other supply, transarterial, 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 and you see what happens. Like you more this, it doesn't. Sometimes it works very nicely transarterially. If it's not, we'll get into that too. But like look at that picture right here. Ultimately, you can get into something like this. Now, a lot of these can be permeated with, I want to say impunity, but it's a low risk distal occipital, permeations. Maybe there's some skin issues that you can have, which are not, unimportant. But a lot of times this is, this works out okay. But this is not, I think it's probably not ideal to see something like this. And in the end, it's still a lot. So here's a couple of other cases, ascending pharyngeal. Now this is a transvenous sacrifice, right? So you see a coil pack inside the sinus, and the fistula is closed. We're injecting, again, this is like an ascending pharyngeal injection. You don't see a shunt. You see this, which we'll get into that. That's that venous channel that we're talking about that you see, retrospectively. These are cases done from long ago, but there's no shunt. This is another case, again, occipital injections. Here's case number 4. You get the idea, ascending pharyngeal again. And this is like, how do you treat this? Injecting this ascending pharyngeal, this is a jugular division. So liquid embolics in this location will carry some risk of associated nerve injuries, a lot of congestion, right? So here's again, like occlusion, right? Coils, a bunch of coils. And then that was topped off with some glue at that time. So this is basically the idea of these like 2 treatments. We'll probably skip over them a little bit. The disadvantages and the advantages of them, I think a lot of you appreciate. The venous advantages is that they can be definitive, simple. If you use bigger coils, they can be cheap. If you use lots of expensive coils, they can be very expensive. The disadvantages, of course, is permanent sinus sacrifice, and that's not ideal. So now we get into something like this. I don't want to skip over that. It's basically just a complication case of showing that it's not, injecting these ascending pharyngeals can have a problem. So retrospectively, now we go back to this, like, why did I show all these cases of like classic treatment? Is that even if we go back, which is what we did in one of our publications, if you go back to looking at these older cases and you see like, well, looking from the standpoint of the channels, you realize that like, if you look at this pack of coils, right? Like, what is this? Why is a coil pack like that? The reason coil pack is like that is because this fistula indeed had this channel. This was before we didn't do rotationals back then for this and for Dynas, but retrospectively, you see from the treatment how that evolves. So here's that channel. Here's that case I showed you before. Again, the sinus is packed, and against the sinus, adjacent, you see this channel here. Here's the other. So this is a picture again. We're showing, so where is the seat of disease? Is it in the torcular? Is it, you see that all of these vessels, this is just an arterial network, arterial to arterial anastomosis, converging on this one channel. They have typical locations. So once we get into this, the more you look, the more you see, of course. And once you get into these, like looking for them, you realize that just like fistulas have preferred sites, like sigmoid is, for whatever reasons, we can speculate on that too, is one of the places where they tend to form. So do these channels have these like slight preferences? And so this one here is pretty common. So here's another one. Again, that's slide from the earlier case. All of this is connecting to this piece. So really the permeation of all of this with whatever embolic you want to use is really should be aimed at getting the stuff into what some people would call the foot of the vein, except the foot of the vein is the foot of the channel. It's not the sinus, right? So this is the target. Okay, so proof. Well, proof, part of the science methodology we talk about. So proof is gathering this kind of proof, looking retrospectively at what we have seen, and then looking at cases that come up and prospectively treating them this way, applying this super selective methodology to cases that come before us. Now, I've showed some of these before, so you'll review them again briefly, and I will show some others. But here's a typical case of a low-grade fistula. It's not a big one, got a lot of pulsatile tinnitus, so he's not a happy person. But it's it's not a high grade situation. Now, what do you see? You see again, there's an external injection, all these occipital, middle meningeal. The usual suspects feed this, and then there is this thing that you see here. That's like the classic channel. So this is the easy one, right? Here's an internal injection. Again, some lateral tentorial contribution to this. Low grade, brain still using it, and the sinus is fine. And that's an important part that we talk about is that, okay, so we'll show you this. So double mask image sometimes looks really nice, right? Arterial mask, venous phase. You see the relationship between the channel, the channel and the sinus, the sinus proper. Here, and again, when this comes to treatment, we could, whatever we do in this dyna, now you see it like this. And so it's like very, this is like a relatively simple case. Now, what happens once you understand this? The treatment, the target of the treatment is doing whatever. So here we have like a Bernstein kind of catheter, helping direct a microcatheter in here. And this is, a lot of times we will use a balloon, dual lumen balloon microcatheter for this, because it allows you to put in the coils, or if you want to put in whatever, liquid embolic. It's more important to understand where to put something than what to put. But we do favor onyx for these, and I'll tell you why later. So typically we would use onyx. So here's a fistulogram. And then you can inflate the balloon, so you make sure that the stuff goes forward, and then just fill it up. And so this is the end result. Case number 2, again, some selective views, middle distal ECA injection. Here's another channel. There'll be oftentimes when you start looking at these, a lot of the time, the main channel is going to be below this sort of mid-sigmoid sinus location. It's going to be down here for whatever reason. Again, like we have this really nice picture of another like Bernstein-Burke type of catheter stuck into the orifice of the connection between the channel and the sinus, and retrogradely inject some contrast. You see this whole arterial arcade here. You realize how like extensive this arcade really is. It's a little bit of like, if you're going to do transarterial embolization, it's just, I think a lot of times it's a little bit hard to permeate this channel well when there's so much inflow coming from all these innumerable things that tends to like either somehow is going to be like retarding progression of either, whether it's NBCA or onyx or whatever you use. That's going to like, no matter how that embolic works, extra inflow is not always very helpful. And so from the venous side, these things are supremely vulnerable. That's one of these other things that we've learned, is that when you really hit it, where it hurts. The stiletto, like you just have to know where to put. And these coming from the veins, a partial transvenous embolization of one of these channels will often, even if it's left just wounded and not completely closed, will often progress to complete occlusion, either while you're watching this, during the procedure or afterwards. So they're very, very, I think, much more vulnerable from a partial assault, if you will, on the vein side than from the arm. So this is the end result. And you can get like some nice pictures. You see where the embolic ends up, and you see how it's really around the sinus, not so much in the sinus, it's mostly around. Another case, again, like here's a balloon. Sometimes we use like a balloon to protect the sinus, particularly with higher grade fistulas. And you could use it to help get in there as well. Here we use the coils, and it worked. Now, typically, I'll show you why we don't favor the coiling thing so much, but it worked out in this case, like that. Now, one of the things that I think we've seen is that this approach is particularly, when we look at channels, like where they are and how often you can find them, it's particularly useful in lower grade fistulas because the angio architecture of the sinus is still preserved. And it's a separate topic. We could talk about what the natural history of these things is, what the progression is, like what we can expect to happen if they're observed or managed conservatively. But what we do find I think we can say definitively, is that when you get to the situations where the sinus is more messed up, if you will, there's some sort of occlusion, either distal or proximal, and it can be debated whether it's based on thrombosis or high flow venopathy or whatever. But once the sinus becomes disorganized, the sinus proper becomes disorganized, the channels often become bigger, and they might be even bigger than what the remaining sinus is. And the value of sinus saving becomes less and less, because when the sinus is already really diseased, often the brain is not using it, or it's not like to salvage it becomes more and more difficult. So one of the values of this transvenous approach is that I think it applies well to lower grade fistulas. And this is the setting where obviously like a lot of the talk is going to be about low morbidity, low grade, this and that. Like we see so many people with debilitating pulsatile tinnitus. And, they might go somewhere and say, oh, look, low grade, leave it alone, do some neck compression. That sometimes works. Not, we're not going to say no always, but there is morbidity that comes even from the low grade ones, and some of them will progress. So we do treat them often. And in this setting, it's obviously very important that the morbidity of the treatment be minimized. And the transvenous super selective approach, I think, is really ideal for that. The other point to make is also that in these lower grade situations, the sinus is usually, still quite healthy, and the brain is often using it. So sacrificing that sinus transvenously can have problems. And so it's often important to preserve it. This is, okay, so moving to some more like complex cases. So here's, we'll concentrate on the sigmoid fistulas today. So it's a sigmoid fistula, occipital. Here's the ICA. And so we understand, obviously it's key to understand the venous drainage of the brain. And you see that it's a right-sided fistula. Despite that fact, the brain is still draining to the right. So it's using that sinus, as you can see. Again, so here's that PL contribution, right? That's the Wolfschlager and Wolfschlager artery connecting to, again, like you see what this connection is. It's like a typical place where these things like to live, these channels. This is, I think it's like the dural arterial connection, but the fistula is going to be here. Now, what you see though, when you inject the left side, is that you see that the left side is also draining to the right. It's a little bit cut off here, but you see how the transverse sinus is hypoplastic here. And this is the left sigmoid sinus that basically exists because there's a little like vein draining into it. But the bulk of your left brain still drains via the perisagittal sinus to the right side. So that underscores the need that whatever you do to this fistula, you've got to preserve the right sinus. That's the dominant sinus for the outflow. And so I think that's like, how do you do that? So this is a little bit more complex. Posterior auricular, whatever the usual suspects. So here's another channel right here. Now we get into like these more dyna and advanced imaging that Eitan showed a few weeks ago. And we acquired those, like you guys have been talking about, all these different protocols. And it's important to get a high resolution reconstructions and so forth. Now, once you do that, you can kind of get a sense of where these channels are. So here's like a typical case. So here's the sigmoid sinus, jugular bulb. You see two of them right here, right? Separated from the sinus, like obviously like it's a separate compartment. And here's the site where they're joining the sinus proper. There's another site over here. And here's like some spot views of some of those things. So the more you look, the more you see. Often, this is like a teamwork. You have, you can compare it to like, any of these jobs where people have multiple roles in some kind of mission. You have an airplane, right? You have the navigator, you have the pilot. So oftentimes there'll be like somebody in the room doing whatever that they're doing. The navigator, one of us is sitting, at the workstation, reconstructing these things, looking at the screens and helping, direct the catheters where they need to be. So the more eyes is always helpful, even if you're in the procedure, obviously. Complex cases like these are, we usually do as several, as a team, fellows, attendings. But this kind of idea, like of somebody sitting at the workstation, processing, looking at this in real time, could be very helpful. So anyway, so now when we get into this, like what to do with this, some of these, in this particular case, the channels, you don't really see them here, and it's hard to see them oftentimes. They're not very long. So it doesn't, what we're doing, this is, some other injections at the jugular bulb level. Now, this is a transarterial approach. And that's to say that once we understand the anatomy of the fistula, or understand it a little bit better, we don't have to stay married to the transvenous approach. It just allows us better to see what the targets are. So here we're coming into, some of these, we could do it transarterially or transvenously. A balloon can be placed, either a non-compliant bigger balloon, or some of the larger compliant balloons to protect the sinus. We are a little bit handicapped here in the States. There are some balloons that are available elsewhere, particularly the Copernic balloon that you might have heard of, which is a large, very large compliant balloon that's specifically created for this purpose. We don't have that, except by humanitarian exemption or something like this. So we can repurpose some other balloons to try to protect the sinus. And you can end up over time, like this is transvenous and a little transarterial embo, with something like this. You see kind of like the onyx coating the walls of the sinus. You have something like that. Visualization can be a little bit difficult. Sometimes it needs a stent. So we put a stent here to help the sinus. Once you have this much onyx in the sinus, I think a stent is a good idea. Otherwise, it tends to thrombose. So we have a stent to protect it. Now we come back a little bit 6 months later, it's a stage thing. So here we have some more residual of that fistula lower down. And here in particular, some of these embolizations transarterially in this area can be a little bit hazardous because the nerves are close by. Brain's okay here. And so here we do like one of these. So again, there's some good anatomy. Here's a dangerous anastomosis. If you want to, push the liquid this way is not so great sometimes. And so here there is a channel that you can get into, and then we can close that. Again, this is transvenous. Again, this approach of like this kind of vert catheters can be helpful in directing the microcatheter in the right place. And then you close that up. We added another stent. So here's some onyx hanging down, another stent. And in the end, it looks like this. And so you accomplish what you do, this preservation of the sinus and get rid of the fistula. The more complex cases, I'm going to show a couple of others that you might not have seen. Let me go to this case. And this is something that really, it takes too long time to get into the anatomy of this. But I think the point of going into like more complicated things is to see how, like, once you develop some kind of tool, right, that you can use in perhaps more simpler situations, you can apply that tool to complex cases where you really need it. So in some of those other cases, certainly there are other ways to deal with the things that we've presented. But, when it comes to something like this, you really can, you need to have all the options on the table. And so this is a person that presents with like progressive somnolescence. He's got like whatever terrible congestion. You can see what's going on. This is one of these cases of like multiple fistulas. There's innumerable fistulas in this person. I don't remember how many we've had, like 5 or 7. There's one, there's one up here. There's a bunch over here. There's one at the torcula. It's like there's a whole bunch of them. And altogether, it's producing tremendous congestion of his brain, which is why he's symptomatic. Now, the important, we do get into like some of this anatomical concepts. Like if you look at this venous phase, you realize that despite all of this congestion, like how is the brain draining? That's key. Like you look at this, most of the people, by this point, most of, in anatomical settings, most people would have developed or would have had some sort of cavernous sinus outflow, which is the main alternative outflow, or, these emissary, diploic veins would have come in to help out. This guy doesn't have. So you see, despite all of these like congestion, he continues to drain. He tries to drain, the superficial sylvian system down into this area because he just doesn't have a good option, which explains in many ways what the issues are. And this is like another topic that we can talk about, is how in the higher grade fistulas, the symptoms are really driven many times when you talk about like grading, right? Or, staging these Borden or Conyard, you talk about the degree of venous reflux, that what's not captured in these systems as much as, and it's a little bit hard, is the degree of venous connections, vena-venous anastomosis, and the existence of alternative outflows. If the alternative outflows don't exist, then you really get into some serious troubles. I think that defines trouble as much as the extent of reflux. But anyway, now you look, we start looking at all of these things. Now you already can see, like once you get the eye for it, here's one. You see that right there. You're looking at these other things. So here's the right side. On the right side, same thing. You see like tons of congestion, fistulas. The guy continues to drain this way. He doesn't have anything else. And here's a little bit of cavernous kind of stuff here, but it's not that good. Superior ophthalmic vein is not doing very much. So really, the importance of this. So once you like look at this, here's the left side again. Like you see this. The point here is that in this kind of setting, you need to preserve the sinuses because he needs them. Like despite the fact that he has all this mess here, you really have to preserve the sinus. And in that setting, like, okay, here's left ICA injection. You see like all of that's trying to come in here. In that setting, that's what you have to do. So now how to do it, we'll get into like, we can just analyze these pictures when you have time. A lot of these field connections you see here. Again, you see that channel, like just like that. Like the more you look, the more you see. Lots of posterior fossa issues. But the bottom line is that, we won't go through these, but if you look, once you've analyzed this, you see like you can identify all of these little things like 1, 2, 3, 4, like they start to like piece this together. Here's a big one, and then it comes like you develop a strategy. And this is like this is a stage thing that's going to take a long time. So we're starting up here, taking this down like one of these sagittal sinus ones. Part of the issue that happens, and we can talk about that, is the development of like venopathy, sinus occlusions, probably we believe due to high flow venopathy or some kind of venopathy situation. It's not really a clot that happens here. It's just a narrowing that develops over time. And so part of the problem with this person is that your sagittal sinus is almost occluded. And so we're going to angioplasty that, give him that back. So we're doing some of that. Now we can get into this channel. Fortunately, we were able to like sort of use the balloon to bounce off of that, get into this thing. If you left it alone, it's not a very big one, but you want to close that. Sometimes it doesn't work. Sometimes it does. Use some coils. That was a mistake because we got bounced out of it. And that fortunately closed over time. Like I told you, it sometimes does, but it didn't close right away. And so forth. So then we get into some of these technical issues. Here's that channel that I showed you a couple of times in the back, like by the transverse sinus torcular. That's this one here. Onyx. Some onyx gets into the sinus. You can pull that out. You can leave it, probably stent it, or you could pull it out. You can pull them out with solitaires or whatever, stent retriever you like. They come out pretty well. Some of them might end up in the lungs a little bit, often does. It usually is asymptomatic. So again, more of that, more and more, like you keep going, keep going, keep going. Here's another one. Again, that spot, some angioplasty. And so in the end, like not bad, you're starting to see some improvement. The brain, this is the brain phase, brain starting to use the sinus again. And look, all of this, like this is much better, right? This is much better than what you started. You've achieved this with just a couple of strategic hits, right? This is like, you're not using, we're not blasting things here. We're just hitting it where we need to. And that's the power of this technique. Anyway, this is a big channel. This is where we made the mistake. So the error here is like this big, huge, juicy channel. So we wanted to try something different. Figured I'd put a couple of these things here, the webs, kind of like coils. The idea was to improve visualization. Ultimately, we're going to fill it with whatever, how to CT him afterwards. And that's a mistake. The mistake for several reasons. First of all, because these are not very thrombogenic in this situation. And second of all, because these channels, and I have a couple of other cases to show if we have time, that the channels, they're not always simple things. Like a channel can have multiple openings into the sinus, right? Like, and that once you see the more complex ones, you realize that you have, like, go back to this, and you can kind of see a little bit of that here. You see, like, what I post facto is marked is that here's a channel, here's two openings, right? Now, if I close it on one end, and if there is still arterial supply coming in, that's going to be coming into this one, then I've painted myself, we've basically painted myself out. And then we have to come into that channel, and that's not so good. So that's why when we talk about using onyx, I think onyx or whatever, it doesn't have to be exactly onyx. It's just we have onyx and glue here, and glue is not as good for this situation. We prefer to use onyx because you can come here with a scepter or whatever it is, clips, whatever you like, inflate this thing, and then push the onyx to this point and use a balloon to protect the outflow. You can fill the channel. It's very important. So because of this, tactical error, I would say, now we're trying to top it off with glue, trying to whatever, rescue this thing. In the end, what ends up happening is that we do, it looks reasonable, but we end up, this is like a second stage. The bottom line is that at some point in time, we end up having to go transarterial because we can't get into that channel on the left anymore. We got a couple of others. We come back to here, and now here we have to like do some transarterial work because that's what it has to take. In the end, so here's transarterial stuff like this. So you see, this is not pretty, but it has to, now we don't really have another way for that particular one. In the end, this is what things look like. I don't want to spend too much time on that, but basically this is the end picture of what happened. And then minus this, everything was done in a transvenous way. And you see how like much better the guy looks. And that's the point. Okay, I do want to show one more case, probably give some time for discussion, right? We'll show. Let's do this one. So, I think, again, a lot of what we talked about is like pushing this transvenous approach. Part of, and because I think I really think it's great. But the other aspect of this is that, as we mentioned, like it's not just like being married to one approach. It's more understanding the disease and understanding where the target of the embolization is. It doesn't always have to be done transvenously, just like we did transarterially. You understand where the target is. And I think this is like just a case to show kind of what happens. Here's again, sigmoid fistula. This is the MRI. So there's some cerebellar congestion, looks like. Here's the right side, a little bit of supply from some occipital anastomosis. Here's, again, like some of this stuff, but you see that there is congestion in the cerebellum, particularly on the left. This is the left injection, left common. Now, what do you see? You see in this case that there's no outflow through the jugular vein anymore. So this is someone that already presents with like an occluded jugular outflow. The history on these can be very typical. The history of this person is the classic history of like, my pulsatile tinnitus got better. A week before this angio, I feel better. Now, why do you feel better? Because it's no longer draining antegrade. Now it's more congesting the cerebellum, so it's worse, of course, from the grading perspective, but clinically, person feels better. So someone who has a pulsatile tinnitus in the dural fistula, if the sound gets better, it's not always good news. Especially in the big ones, it's usually bad news. Now, so what you see is like, obviously now it has to, like, there's some retrograde flow, there's some cerebellar congestion via this connection to the superior side, to the superior petrosal sinus. And so in this particular case, like, what do we do? Like in this case, like basically this ended up being a sacrifice, a transvenous, just classic sacrifice of the sinus. Because really there's not a lot of, the brain is not really using this one too much, and coming up from here is a little bit might be a little bit difficult. However, the feature that I wanted to point out is something that we appreciate. Maybe if we see a little bit more on this dyna, it's a little bit big, but I'll show you when we did a dyna of the vertebral injection, which is here. Let's see if we can run through that. Oh yeah. Okay, so when we see this, right, we run through this injection. We can identify some channels that I will show you, but we're not going to use them. What we do notice, however, the important thing is to appreciate where the brain drainage is. And so the brain drainage, which we'll see from the ICA injection as well, is coming into one of these tentorial sinuses. We talked about the tentorial sinus, which is here, and the tentorial sinus, which receives some of these cerebellar veins. I don't know if it's projecting very well. Let me see if I can find it. By the way, here's the channel. Look at that. You see that right there? This here is the junction with the tentorial sinus. Doesn't project very well, unfortunately. But what we do see on this injection is this little stenosis, right? It's little, meaning focal, but it's actually quite significant. And this is really like where we get into some of these things that we don't understand too well, which is the evolution of these fistulas. At some point, presumably, this outflow was patent. Now it's not. Why? We think it's high flow venopathy. Whatever mechanism that is, now that's closed. Now what's next on the plate? Next on the plate is this is starting to close, right? Once this closes, the only place this thing can go is this way. And at that point, probably there's going to be trouble. At this point, the trouble is just pulsal tinnitus, but there's no dysmetry or anything like that. But this is how these things progress. So I think the natural history is the progressive occlusion here that would lead to more trouble. Now, right here, if we go back to this, which is the injection on the left side, you appreciate how a lot of these veins are draining into this spot. And so the main key with transvenous, like not super selective embolization, is making sure that we preserve these drainage. Because if these get occluded, if we extend the coiling or whatever and close this, that's not going to be good. That doesn't look like there's alternative outflow. There's probably going to be a venous impulse. And so here, again, like the dyna allows it to understand it a little bit more. You see this narrowing. Couldn't show it very well in this dyna here, but that's really where we kind of picked up on that. Now, once you appreciate that, we can get more views. So here's a O2-7 catheter in here, and then we can get a venous injection. Appreciate where this is. And this is really where we need to stop our coil occlusion. So this is a classic case with a twist, maybe a little bit. Like here's again, like all these ways to try to understand the relationship between the sinus and the normal drainage of the brain. We use the, these Ruby coils. They're big. You don't have to use as many. They detach better than they used to, or not detach when they don't have to. So I think we've been using them for this kind of purpose like that. And again, like being very, very careful to stop the embolization where we need to stop it. Okay, so another maybe 1 minute to go back to this, where I think we kind of like want to get into some of these things, like where to go from here in terms of anatomy. One of the debates that I think has clinical implications is whether these channels are arteries or veins. Most people believe that they're veins. The people that are into that believe that they're veins. We've published on kind of the alternative that they might be arteries. And I think this is actually like more in the question of, well, either sometimes the arteries or veins or one of us is wrong, right? It's hard to know. I think histologically, there is some evidence that they're veins. So I think it might be that's like what the original belief of ours is, that might not be correct all the time or any time. They might be venous. It has some implications as to where the channel needs to be occluded. If they're arterial, then you just have to occlude the inflow. If they're venous, then you probably need to occlude everything. The other, these are some of these arteries and the walls of the sinus that we've shown. The other question that I think we can try to like start to understand with a little bit of work in the meningeal work that we've done is how do fistulas form in particular spots? When we do dynas or we inject the meningeal arteries, we understand that there are some pockets that form in particular spots. There seems like there are pockets of either venous or arterial networks that we tend to see like in this area, which also tend to be sites where the fistulas form. And so here's a dyna injection. You can really see these networks in the walls of the sinus. Here's one like that. This is something that we see often, right? If you're using onyx for MMA embos, you're going to see something like this. Now, what is this? It's basically some kind of rupture, right? The onyx ruptures into some other space. It's a self-sealing tank, kind of, so nothing happens. But where is this? Like, is this in the wall of a venous channel? So is this basically like the angioarchitecture, the normal sort of, like the normal anatomy? There's no fistula here, but is this kind of like an insight into what might happen if a pathologic connection were to form like this, not by pushing the onyx here, but for some reason a pathologic arteriovenous communication would form like that, you'd have a dural fistula. So anyway, I hope it's been interesting. Again, it's a team effort, as Eitan showed. This is like part of the core of our team, and as he did, I want to invite you to our hopefully happening banana course. Who knows? Best laid schemes might go astray by the fall, but hopefully they won't. And so we're planning an in-person banana, like applied anatomy course at NYU. Hope you can join.
Thank you. Yeah, you can stop sharing. Thank you very much, Dr. Shapiro. It was amazing. I'm here with my co-fellows, Dr. Bassam, Dr. Samshi.
Thank you guys.
Really enjoyed this talk. So we have many questions. I'm going to start with we were looking at your series, this paper that you showed at the beginning with Dr. Nelson, etc. And you spoke a bit about it, but maybe you can go deeper on the. Could you change the approach if you knew that this was a venous collector versus a common arterial collector? Does it change?
Probably at this point, practically, it doesn't change much for us now. Initially, we were kind of like, I guess, intrigued. I don't know, like we were a little bit more excited maybe about development of just technique to just occlude the point where that channel gets into the sinus, right? Because if this is an artery and if there are no other connections, then you could just put like a tiny little plug there, and sometimes it works, like, right, those coiling cases that others and one of ours, like, it works like that. What we found is that for practical purposes, if that channel has another connection to the sinus, then closing it at one end just paints you out of the other. So at this point, like, what we prefer to do is basically like the go-to thing is onyx, like, and I think it's part of like how stuff develops. Like you develop some technique, you're trying this, that, or the other. Eventually you settle on what you think works, like, what the optimal thing might be. So now usually it's like a balloon, a dual lumen balloon, and onyx just gives you different options. We will often use a balloon, put a balloon in the sinus to protect the sinus, to inflate it and try to control, like, if there's if there's onyx spilling into the sinus from one of these. Definitely, like, the balloons can improve, like having like a bigger balloon is, or we've used non-compliant, like peripheral balloons. You could use, like, the Armada we have or whatever. They're just stiff. They're just like super stiff things, and it's a little bit, it works sometimes, but depending on the anatomy, may not be so.
And in your series, you show that the common collectors are more prevalent in low-grade fistulas, like Borden 1 and 2A.
Yeah.
And what do you think that happens?
I think they're like I think well, the more we look, the more we see. So I think we see them in higher grade fistulas too, like I showed in some of those other cases. It just, I think the sinus, like the sinus itself, the sinus proper gets more diseased. Like it becomes narrow, irregular, parts of it occlude. And so it becomes more difficult to tell like what's what, you know? But I think at the connection, I think the original pathoanatomy is like that. Now, how that evolves, I think is different in different people, or what's left by the time we get to it, or you have like a trapped sinus completely. You know, at that point, like it doesn't really matter. You're not saving anything. But I think the angioarchitecture, and the more we look again, the more experience we get, I think they're actually common in all of them. It might be harder to see or may not be practical to like exploit them.
Okay. Could you dig a bit more in the choice of embolic materials in your?
Yeah, like I said, I think for these, like we prefer onyx for those reasons that I explained. Really, like, you know, what you have. You got onyx, you got glue, you got coils. All these other things, like, you know, I really like not, you know, we tried the web, or we've done like, you could try like using an Amplatzer, for example, to like close the sinus itself. It's a little bit less radiodense, but it's not, you know, it's not made for that purpose. So practically it doesn't always work.
Okay. And do you prefer to study the
onyx? Mostly we use 18, just because like if we need to go a little bit further somewhere, like it's probably a little nicer. So we tend to use that.
Okay. And you prefer to study this the presence of these common collectors? How? I mean, do you think the dynacity is better than the angio?
I think it's everything. I think the more you look, the more you see. Like once you get a hang of it, like you can see them on angio too, just DSA. But I think Dyna is right now. I think Dyna is best. It's just you have the most, you know, spatial resolution. You don't have temporal resolution, of course, but you have spatial resolution. And the more like it's only going to get better. You know, on the Q, you need a 20-second Dyna. On the Icona or on the Pheno, like a 6-second Dyna is probably enough. So like it's only going to be like less, you know, less radiation, less contrast, the same, you know, the same bang.
And have you seen transformation from low grade to high grade using the common collector?
In what sense?
I mean, transformation as a complication. For example, you are treating abdomen, transformation to higher grade.
No, not yet. Not yet. No, I think okay. If you mean like, well, okay, so we've never seen like one come back. Like once we occlude, once they're closed, they're closed. It's not like a fistula comes back as a higher grade. What I think, if the question is like, can you like somehow basically embolize, like put the embolic material somewhere where it shouldn't go and result in like say a sinus occlusion, now the fistula refluxes into the brain. We haven't had that happen, but it can. I think it can happen. It just like it has to do with like where you're targeting the occlusion.
Okay, and what about this concept of the common collector in, for example, cavernous, CC fistulas?
In indirect dural CC fistulas, yes, yeah, absolutely. It's more like I think it becomes more of a compartment. I have a couple of cases, but we're not going to show them. Yeah, it's the same thing. I think it's always compartmentalized, like in always. But like say if you have a cavernous sinus fistula, usually they're like posterior, right? Like posterior, like there's a posterior like that. You know, if you look at the distribution of them, if you look at the compartments, usually they're very compartmentalized in the cavernous sinus as well. It is oftentimes possible to like also super selectively close one of those if you get into the right venous compartment in the cavernous sinus. I think it is probably more, it's a little bit because of how the cavernous sinus is. I think it's a little bit more likely than if you try to do that. If it doesn't work, that you're going to end up painting yourself out. Like now you're going to, like you will have lost the axis, like the axis, now it's draining anteriorly or whatever, something is happening. You can't have access to it. We had one case like that. That's like we tried to do this and that. And in the end, you see that it's still alive, but it's hard to get to it. So I think in cavernous sinus, like a lot of times the brain is not using that sinus, right? Like once the fistula is there, sometimes there's a lateral cavernous sinus that we talked about. So the lateral cavernous sinus might be like used, but the coils are not likely to go there anyway. So I think in cavernous, look, a lot of times you could just like fill the whole thing and you'd be fine, just to be sure. But in terms of the anatomy, I do think it's like that too.
So one of my partners here has a question.
Thank you, Dr. Shapiro, for great presentation. I have one speculative concept, and then just to get your thoughts on. So, the results of radiosurgery for dural AV fistulas are generally not good. But what if you apply this concept of common venous pouch with this, 3D high resolution angiography that you're doing at your institution, and you combine that with a radiosurgery approach? Does it have any conceptual merit to you?
I don't know. I'm not sure. If I had to guess, I would guess probably it's not going to be that much better than what we have now. It's just a guess, because I think when we do radiosurgery on these, we don't usually do that. But when we have done it, we tend to target like the whole area. Yeah. So I don't know if so the whole area gets the, whatever the target dose is going to be. And the doses, people tend to use high doses there because they know that efficacy is lower. And, so there's something about the vessels there that makes them like more resistant to this approach. That I don't know why that would be. But yeah, I think radiosurgery for these is reserved for like very specific cases.
One more question is, and you touched on this at the end of your presentation, but any speculation that you have on the pathogenesis of this disease? It's very enigmatic, and as far as I know, no one has a clear explanation, but from a leader, perhaps any speculations that you have?
I think it's probably just remains speculative. Like certainly, definitely some cases are preceded by venous thrombosis that we clearly we know. I'm not a fan of like saying that this is the case for most of them, because we would have to then assume that there's a lot of like asymptomatic venous thrombosis going around before the fistula development, which I don't know, just doesn't sound right to me. But I think as I said earlier, we don't understand a lot about the pathogenesis. The anatomy, I think we can get into these issues like why fistulas form in that particular sigmoid spot, for example, because I think that the arteriovenous networks in the wall of the sinus tend to be richer there, maybe, so there's more opportunity for that to develop. I think it's I am limited in that.
I have another question. Your group is publishing about the dural lakes and dural sinuses a lot, even with DynaCT you found
yeah.
Do you think what is the relationship between them and fistulas? Why do you think they are related?
There is a relationship, I think, in some of them, and the relationship is that when you see why do you sometimes see fistulas on the convexity that don't seem to be connected to any sinus that we know of, right? There's an artery goes into a cortical vein. How does that happen? I think it happens to one of those channels. I think what happens is there's a channel. Usually they're located close to what would be the superior sagittal sinus. The favorite parts of those are either here, right up here. You see some of them. You see some of them down by Lilla Bay area too. How does that happen? I think it happens because the original fistula site is located in that dural channel. Now you'd have to assume that the other outflow had closed somehow, but we see that, we see that happen, and then it becomes one of those. So I think there is a potential relationship.
Okay. Dr. McDougall is back. Any comments, Dr. McDougall, or questions?
I don't want to duplicate stuff, but I do want to ask Max, what balloon were you using on the sinus? Because I haven't found a great one for that.
Yeah, no good ones. Yeah, no, we once like got to like we needed a case that we had to use the Copernic, so we got the Copernic through like FDA, whatever.
Compassionate use thing.
But yeah, we use like if the sinus is small, I use like 7 by whatever, transform or something, or hyperglide or something. Or Kim favors using body like peripheral balloons, like they're
Right.
big, these big peripheral balloons. If you can get them up there, that's great, and they don't pop, and they're just like everything. So yeah,
they're not compliant enough though, really, for to give you a nice seal without using high pressures.
they don't conform. They're not. Yeah, it's no good. No, I don't think there's anything great.
Yeah, I enjoy telling the story because of sort of how I started understanding these venous pouches and the receptacles, and Van Hallback, when I was a fellow, I did a case with him, and I did the whole case with him as the fellow. And at the end, the sinus was open, the fistula was gone. I didn't have a clue what had happened. I couldn't understand how he did it. I couldn't see, what now you demonstrate so beautifully with the Dyna-CT images, but he was able to see that on the older technology. And I kind of sort of, was there and saw it, and I was scratching my head trying to understand it. And then when I was on my own, I went and I did a case and I closed the wrong channel. And then I understood how it all worked. And so it's one of the real pitfalls if you don't really understand that anatomy. And I learned, to get the microcatheter in the pouch on the venous side and another microcatheter as close as you can on the arterial side, and make sure the two match when you're doing your microcatheter runs, and everything lines up, and you don't close the wrong pouch. And then fortunately, the patient I did it on taught me a lesson without me hurting the patient, and ended up then finding the right pouch and getting it done. But it was a sinus I could have salvaged had I really had that understanding of what Dave Fiorella, when we started calling it the parallel universe of the pouch.
Yeah.
Mohammed, yeah.
I think more and more, like, obviously, like we all have these experiences, right? Of these cases where this can be done, going back to this. And I'm hoping that like really this technology, the wider application of like Dyna and us, like as practitioners, highlighting these cases, that this leads to not just like better, like, first of all, that what I believe is that the channels are like pretty much always there. Is that when we see them with new technology, we see them pretty much all the time. You can't always get in them. You can't always,
Right.
It doesn't always work. But they are there, and the more we use them, I think the safer and better we're gonna do. So,
Yeah, there's seeing them and there's accessing them. They're it's not always but they are there and definitely underappreciated. And your work is beautiful at helping educate us on that.
Mohammed?
Dr. Shapiro, how would you translate the understanding of the pouch and the anatomy in the 3D Dyna-CT to the angio images? I can imagine it's not always straightforward.
Yeah.
Do you have tips for that? How did you?
Not always straightforward. No, I think it's hard to see them. It's not always straightforward. Sometimes. And it's good when you have a couple of people, like I said, like you get the navigator and the pilot, like like you've seen. So sometimes that helps. It helps. Oftentimes, what helps is injecting subselectively. Like if you inject like the whole ECA, it's just too busy. When you get into like one of these particular, whatever it is, some artery, you can sometimes see the channel a little bit better. You don't see the sinus as well, but you see and oftentimes it's diluted by some other thing that's flowing into that channel too, right? But if you can get a little bit of more like an isolated injection, it can tell you where to try to go with your microcatheter. So that's one tip.
Yeah, it's a little obscure branch off on the contralateral side.
Yes, like that. That's that channel that tends to be more. That is usually contralateral. And sometimes, it's also like some of them, they point different ways. Some of them are easier to get into, or you can see how you get into from coming up from, the ipsilateral sinus. Others, you have to come from the other side. And sometimes you can't come from the other side because of how the torcular is or whatever. So, it doesn't always work.
Dr. Montit has a question.
Maksim, that was a great talk, and thanks for joining us. My question is about the stenting. So do you put patients on dual antiplatelet therapy when you think you might need a stent, and how often do you stent, and are you using carotid stents for these big sinuses, or what's the kind of game plan on that? I haven't seen that before. I was curious as to the use of stenting.
So, okay, so yeah, we don't put them on dual antiplatelets from the get-go. We try not to stent. I try not to stent, of course, unless you need to. And the need is would be like in the case where, like, say you need to preserve a sinus, but you have enough onyx spilled in there that like I might probably want to put them on whatever, either anticoagulation or on something anyway, so they're already going to be on something. So in that setting, we've used stents sometimes. Kim has been, like, even going back before, like, all of this stuff, like going back years, he advocated using stents combined with transarterial embolizations, using stents to kind of protect from if the glue is coming in, you could use that. So we have had like some history with that. But yeah, we use like carotid precise or carotid wall stent, whatever the usual suspects.
You haven't had any issues with it kind of cheese grating the onyx and going to the heart or anything like that?
Yeah, it's what I mean. It pushes it. It does whatever to it. Definitely, like, some pieces will fly, maybe. I don't think it's, we haven't had issues with, like, there's often embolic material ends up in the lung, a little bit of it. But I think it's very good for keeping the sinus open. We've had a couple of cases where we just use the balloon at the end. Like if we have one of these like non-compliant balloons, just like try to squish the onyx against the walls. In one case, it closed later. So I think the stent is a little bit better for keeping it open, and they end up on dual antiplatelets. So we will give like integralin or whatever, intraprocedurally, and then start them on something. What I've tried to do, and it doesn't always, the conceptual idea is like if you are dealing with like a really complicated fistula, and if you're not sure if you're going to need a stent, to bring an exchange wire, like from the get-go, put an exchange wire across the sinus at the beginning, leave it down there somewhere, so that at the end, if everything is like you can't see and whatever, you can ride the stent along that. You have a way in. So that's another trick that sometimes works, sometimes it doesn't work. You have to take it out for whatever reason, but it's like a little insurance policy.
Great, thanks.
Okay, so I think we have no more questions. Honestly, spectacular talk. Thank you very much for your presence here. We really appreciate it. And,
thank you guys for having me. Thank you very, very much. It's a pleasure and honor, and good luck with everything.
Yeah.
Again, thank you.
Okay.
Yeah, thanks so much, Max. Really enjoyed it. Great seeing you.
Thanks, Maksim.
Thank you.
Bye, Maksim.
Bye now.
Bye-bye.